Good morning, everyone. Very welcome back to Health Committee, back by popular demand. I hope everyone's summer is going well, and we are catching some respite from COVID and getting to relax and restore, perhaps. With that, I would first invite, has the roll been called, Ms. Hill?
Yes, Mr. Chair, the roll has been taken.
Thank you so much. The next item, are there any disclosure of pecuniary interest, and if so, the general nature thereof? The chair recognizes. Can I have a motion, please, to adopt the minutes of the previous meeting held on June 16th, 2021? That has been moved by Councillor Love, seconded by Councillor Bennett. Any errors or omissions? Seeing none, all in favor? That is carried. Thank you. There were no delegations at time of mailing. I have not been made, none have been made known to me since. I'm presuming that is so, Mr. Morrow?
That is correct, Chair. Thank you.
Thank you. Then without any further delay, we will go directly into the Emergency Services Department report. Please, Chief Nolan.
Great. Thank you, Mr. Chair. Can you see me okay?
It's a lovely background. Perhaps you have discovered invisibility.
There we go. I have
there we
indeed,
are.
actually.
Just like magic.
This is pretty fantastic.
You're phasing.
Right.
I know that from my Star Trek fandom.
Well, yet another arrow in the quiver. Thank you, Mr. Chair, and to you and to members of committee. It's my pleasure to report to you a number of what I would consider very strategic goals, and hopefully we'll have a little bit of opportunity for dialogue related to those items in today's report. While it's a short report, it's actually quite deep in terms of our strategic plan and moving forward on a number of things that are near and dear to many of our hearts, not the least of which being the continuation of RCVTAC. But item number one, as a matter of business, Mr. Chair, looking at the 50-50 land ambulance grant funding. So just as a reminder for everybody on committee, that we provide the ministry last year's actuals and budgeted amounts, and then by the end of March, everything is submitted in hopes that beginning April 1st, we'll know how much money we have to spend in the coming year. That is not, nor has ever been, our reality. And in fact, it was only this month that we received notification from the province as to how much funding increase we would receive in relation to what our planned expenditure was and what our previous expenses have been. So it's always a bit of a guessing game, frankly, but I am pleased to say that the ministry has gotten back to us. This is earlier in the year, I think, than they've ever gotten back to us. And as it relates to the letter, the ministry's base funding total will be at $9,050,900 or $9,050,987 for the 50-50 land ambulance funding, and that's coming within $3,000 of what our planned amount was. So we're short by $3,000, but in the grand scheme of things, as it relates to almost a $10 million ministry contribution, it's very close to what we had projected and predicted for this year. Of course, it's always based upon eligible funding amounts, so and previous year's actuals. So I think that overall, that's very close to what we expected. Item number two, related to the Virtual Triage and Assessment Center strategic plan. There is a document that's been provided to committee that I'm happy to run through, Mr. Chair, either at this point, later on, or if there are any questions related to that document. There was, of note within the budget related to the document, we had done a 7 out of 12 month calculation on costs, when in fact some of the costs are fixed annual costs versus those that would be 7/12 in the overall budget. But materially, we're coming in at roughly $1 million in terms of the VTAC costs in the proposal to government, and that is parsing out the physician salary component as continuing with the existing policy framework of assessment center funding and funding through OHIP. So very pleased that we've been able to work with our partners at the Empire Hospital, or Empire Regional Health as it's now called, as well with the Empire Family Health team and others. And I think that it's important that that committee understand the proposal is about solidifying the role of VTAC as being complementary to primary care, targeted at populations who principally do not have access to primary care, meaning the 27 to what will at the end of this year be 30,000 people across Renfrew County. And we know the value of this program. We've been able to articulate well the challenge, as well the opportunity and the ask of government in terms of being able to support the back-end administration, the role of medical reception, and the continued participation of community paramedicine, albeit at a lesser rate than the full amount that would be supporting this. But we see community paramedicine as a whole as being able to support this program so as to be able to ensure that the funding goes for the continuance of VTAC. So maybe I'll leave it at that for now and come back to it, Mr. Chair, at your pleasure. Item number 3, from a vaccine update perspective, excuse me, as the demand for vaccination decreases, and many of those in Renfrew County have already received their first vaccine, we are continuing to right size the participation of paramedics in the vaccination process here in Renfrew County. But also, I think it's important to note that we know that there are, what I'll call subpopulations or areas of the county that we've not served through vaccination clinics, because we've asked people to come to some of the larger centers within Renfrew County. So we've begun doing pop-up vaccination clinics where you do not need a pre-booked appointment. So we're trying to appeal to all of the different dispositions as it relates to vaccination and do everything we can to make sure that everybody's had opportunity to be able to come, get vaccinated, and continue to protect themselves, but also to continue to protect the community at large. Mr. Chair, we also have a bylaw in relation to the virtual triage and assessment center, where we are
perhaps,
transitioning.
Chief, what I would prefer to do, since items number 2 and 4 are directly connected, and I think probably a presentation on both the proposal and how it pertains to the bylaw that will put in place the proposed structure. We'll leave bylaws for now. I'll review the first 3 items, of course, recognizing number 2 and number 4 have that connection. So we'll just pause briefly there, and I would invite committee, I'm just going back to my agenda. Any questions or discussion on item number 1, the additional $414,000 provided by the Ministry of Health for the base paramedic funding? I see none. I had one comment. I note that, and I don't know what may have changed subsequent to that, but there were budgetary pressures identified when council was reviewing and adopting ultimately the budget in January, or perhaps it was February of this year. I've kind of lost track of that a little bit, and I do not know what the actuals are at to this point either, but presumably this extra $414,000, as I'm looking, there was a $115,000 budgetary pressure at the time that the draft budget was presented to us. So certainly this $414,000 should obliterate that budgetary pressure. Any comment on that, Chief? And I recognize that Mr. Foss is, Mr. Foss has joined, I see. Perhaps defer this to Mr. Foss. Certainly, Chief Nolan, if you wish to take the first stab at it.
Yeah, sure. Thank you, Chair. And I think, the provincial funding related to paramedic programs is complicated at best. When we think about the 911 program, the legacy program of the department, we look at our annualized budgeting as it pertains to that. And this is where the incremental increase of $400,000 or so is kind of the kind of the annual amount that we've roughly relied upon year over year, depending on the previous year's expenses versus this year's. We have a number of pressures to our budget, not the least of which are COVID related. So what's not being presented here are the contributions that the province had made for COVID related costs. And the province has assured us that in addition to this amount, the COVID related costs will be recognized and reimbursed as they did in the first quarter of this year for last year, as you may recall. So I anticipate that any of the budget pressures that we've talked about, the $100,000 or so that you speak to, will be able to be absorbed within the COVID related costs. And of course, you know, there are a number of other 911 related pressures that are either directly or indirectly related to COVID, and not the least of which is overtime and the health system pressures across the system. So when I look at this 414,000, while it is short of what we specifically asked for in the grand scheme of things, it's not a substantial amount. But it is short. So, you know, we're always trying to aim for the 50-50 and that balancing. And we know that it's somewhere, you know, usually within a point or two of that. But when we look at the other revenues to be able to offset the other pressures that we have as a department, whether that be our involvement in vaccination, in VTAC historically, or the pressures to our base funding, such as this, that will truly be COVID related. I think that this is a reasonable effort on the province's behalf to be able to maintain 50-50 funding. But I think as importantly to me is we're learning earlier in the year what our amount is. We've heard in the middle to late fall previously. So while it's not exactly what we wanted, it's appreciated that it's coming when it is. And I think that the balance of the shortfall that you speak to will be able to recognize as COVID related costs and be able to move that forward.
Thank you. And I offer up the opportunity, Mr. Foss, if there was anything that you wish to add.
Thank you, Chair, and good morning to members of the Health Committee. The letter that Michael spoke about is certainly a letter that we receive every year, and thankfully we're seeing it earlier than we typically do. So we're very appreciative of the efforts that the province has made to get this funding announcement out to us earlier. We participate every year in an exercise. It's called a planning document, and we file the planning document in the year 2020, looking forward to receiving our 2021 funding based on the 2020 planning document, which contains 2019 budget and 2018 actual paramedic 50-50 information. So I believe I may have mentioned to this committee previously that when we receive funding in our current year, it is based on 2-year-old information. So it's not necessarily representative of what our actual expected costs are in 2021. It is based on our experience 2 years prior. But we can be rest assured, we feel fairly confident that the province has continued using this same planning document process for us to estimate and calculate what our funding will be. And so, you know, they followed the same process. And so we are within $3,000 of what we expected using this planning document format. So that is for our 50-50 paramedic funded program. In addition to that, as Mike has mentioned, our 2021 budget does not reflect any exposure to our local ratepayers for COVID-19 mitigation costs, because those have been last year and continue to be this year fully funded by additional revenue streams from the province of Ontario. In addition to that, the paramedic service has a number of other programs, which would be the community paramedic long-term care program, the VTAC program that we're involved in, as well as our historic community paramedic programs. And all of those are funded in addition to this 50-50 funding program that you're looking at right now. So it is good news. The province has been true to their word and continued to use the same calculation basis for the largest program that we operate in paramedic services, the 50/50 or the 911 program. And so that's good news. We received pretty much what we expected to. Thank you, Chair. Happy to answer any questions.
Thank you, Mr. Foss. And the process that you describe vis-a-vis the planning document and the review of past actual expenditures and the timing in the year certainly mirrors that of public health too. It seems to me that the paramedic service and public health I think may have been the only medical services that remained outside of the LIN structures because they seem to have the same funding model. I know that it has often been even into early fall before there was confirmation of what base funding was actually coming to public health, similar to the paramedic service. In any event, any further questions on the follow-up funding from the Ministry of Health? Seeing none, I'm going to skip over item number 2 and address any issues when we address the bylaw. Anything further on item 3, the vaccine update? I see none. Just a comment. I want to certainly commend the paramedic service, the County of Renfrew Paramedic Service for the continued work in meeting our residents where they are needed in the vaccination rollout. Certainly also any other and all other agencies that have been doing the outreach. Certainly I expect that the Health Committee is likely aware that from the early part of July through to now, the daily vaccination counts have plummeted, I think from a high of something like 220,000 at its highest on a daily basis, now to bouncing somewhere between 40 and 50,000. I also wanted to comment that sometimes it is the perhaps skeptical, at least, or hesitant that are identified as those that are keeping the number down, but it certainly does seem to be socioeconomic factors are a much larger component of this. So certainly commendation to the innovative delivery of vaccines. That initial queue that lined up for blocks and blocks and blocks has now been satisfied, and that euphoria that arrived when the vaccines became widely available has now become a lot more legwork and initiative. So commendation certainly to the paramedic service for that outreach into our community and help us get to herd immunity, which still remains a very elusive challenge. With that then, Chief Nolan, I will defer back to you. The floor is back to you for item number 4, please.
Yeah, thank you, Mr. Chair. So item number 4 and 2, as you, Mr. Chair, identify, are kind of inextricably connected in that really there are 2 parts. The first being the conversation that we had previously about the County of Renfrew assuming the responsibilities from our family health team as it pertains to the medical reception and the secretariat functions or the administrative functions related to VTAC. So I think it's important that people understand that there is existing funding, and our first movement as it pertains to VTAC beyond our existing involvement is that we will and have begun and will be on time for the transition of the back-end secretariat functions of VTAC and medical reception during the month of August. So that is well underway. I'm happy to report that that is moving forward. And the proposal that I put before you is also about petitioning the minister and ministry about continuance funding should the ministry discontinue the role of assessment centers, or should they evolve it into a different model. I think it's important that the ministry understand the impact of VTAC on issues related to access to primary care and the secondary intended consequence of reducing pressures on 911 calls and reducing pressures on our hospitals and emergency departments, because they are under enormous strain this summer. Our 911 calls have become more frequent, more complex, and are taking longer to do. So really the three elements that create a perfect storm in terms of volume and pressure on our frontline staff. And the hospitals similarly are feeling significant pressures, not only related to volumes, but also related to staffing pressures. So when we look at items 2 and 4, really one is about saying we have an agreement in number 4, looking at how we will be transitioning VTAC to the county and the functions and the directions that I had received from Health Committee and Council last month or in June. And then secondly, what we are asking the minister to do to be able to solidify the role of VTAC as a service that is delivered on a continuous basis in the County of Renfrew. So, Mr. Chair, I'm happy to read the recommendation or leave that to you. I just want to make sure that committee has an ample opportunity to understand how really we have a part 1 and a part 2 in this series. Part 1 is the continuation based upon the direction received from committee and council to take over the functions of the Arnprior Family Health Team. Arnprior Regional Health is the legal name of the Arnprior and District Hospital, and I think it's easily misunderstood. So I want to make clear that the Arnprior Regional Health is the paymaster. So the funding goes from the ministry to Ontario Health to our Arnprior Regional Health. And then the funds have been historically dispersed to the Arnprior Family Health Team and the County of Renfrew Paramedic Service for their participation and involvement. We will be the sole funding recipient through Arnprior Regional Health for activities related to VTAC on a go-forward basis. I see Paul has his hand up, Mr. Chair, and happy to answer any specific questions or provide more content, but I think most people, and I think the City of Pembroke importantly, as part of this, and many of the patients that are receiving service related to VTAC are from Pembroke and area, and we've heard clearly that this is a valued service. So just want to make sure everyone's on the same page.
Thank you, Chief Nolan. And just before I will go to Mr. Morrow, just before that, it was not my intent, and hopefully this is not confusing the issue. Of course, item number 4 is the continuation of VTAC in its current guise. And number 2 is what VTAC can and should be doing on an ongoing basis. But I think that the presentation, I think it would be worth going through that as well, not to confuse the issues, but I think it was an exceptionally well done report on what the future of the scaling, the costs. So I would like to have that reviewed. This seems like it would be an appropriate time, but I will first, Mr. Morrow, Chief had advised that you had your hand up.
Thank you, Chair, and through you to the Chief. And Chief, if you're going to cover this in more detail, just the question as to, why we're needing to go to the Ministry of Health for a fund that looks like it's dedicated to respiratory issues when we know that VTAC is much bigger than that. So, I'm hoping you're going to cover that off in your presentation. I see and with respect to item number 4, Chair, my second question is with respect to the MOU. I would point out to committee that it is in place until March of 2022. So it's an opportunity after that to us to revisit the terms of that MOU to provide clarification beyond March of 22. And we're most certainly hoping that this is going to go beyond March of 22. But I did want to highlight the timeline of that MOU so committee is aware.
Okay, go ahead.
Finally, on that, this MOU that you see with respect to item number 4 is very similar to what we've done with the assessment centers. Although when we did this during COVID, it wasn't the cleanest MOU. I think Mr. Foss will tell you that we have submitted invoices to Arnprior Regional Hospital, and we have being paid for the services we provided. So that has set a good precedent for us as well, Chair. Thank you for that.
Thank you very much, Mr. Morrow. And I will note that there was some significant urgency when this was stood up. And again, I think it is to be commended. 12 days. It took 7 days to create the universe. It only took 12 days to create VTAC. I think that this was an incredible accomplishment. In the end, perhaps there were some T's left uncrossed and I's perhaps undotted, but sufficient fingers were available to plug those holes in the dike. So I'm very appreciative of that. Anyway, with that, I did note that Warden Robinson, you had a question or a comment.
Thank you very much, Chair. So I have read through this proposal. I think it's absolutely excellent. If someone didn't know anything about VTAC, when they finished reading these pages, they definitely would know exactly what it's about. So I am looking forward to Chief Nolan going through it with us. The only thing that I noted, however, is that, and perhaps I did miss it, was that there isn't any mention of the K codes for the physicians. So without those sessional fees being paid to the physicians, VTAC can't operate. We don't have any docs involved. So it's crucial, like that, this is one part of the puzzle, but that those billing codes must remain in the long term for VTAC to operate. Anyway, I'll turn that over to yourself, Mr. Chair, and Chief Nolan.
Thank you, Warden Robinson. And once more, I think inadvertently, I want to ensure that I am not confusing committee when this comes to council. Perhaps it would be best to accommodate it in a different fashion, because essentially item number 4 is a continuation of VTAC in its current guise, though recognizing that its current guise is encompassing a great deal of what needs to continue, even as perhaps the COVID pressures and the assessment, testing, vaccination roles may diminish as COVID increasingly gets into the rearview mirror. Essentially, it is a continuation that we are talking about, but item number 4 is simply a continuation in its current guise. So I want that to be made very clear to committee, and we will address this in a different fashion. However, having said that, echoing the warden's comments, it is an exceptional report on what the need for VTAC is on an ongoing basis. So I would very much appreciate Chief Nolan if you could give us an overview.
Yeah, thank you, Mr. Chair. I was attempting to share my screen. So I'm not sure who's got the host handle right now, but I'll likely need that back. Let me see. Nope, still cannot.
Ms. Hill or Ms. Grunts are the host.
You should be able to now, Mike.
Okay, I'll give it a try here. Just one sec. I'm trying to do this on an iPad. So this could be good fun. Give this a try.
It is being shared.
All right. Can you still see it there?
No, I think we're seeing something else, Mike.
We're seeing a different screen, I think, than the one you want, but you do have the capacity
How's
to
that?
share it.
We're seeing the boat.
Nope.
Okay, good.
Are you seeing the report now, Paul?
Yes, we are.
Okay. Very good. So what my intention, Mr. Chair, was to walk through some of the program, really the highlights of this document. So you're seeing the applicant information at the top of the screen now, is that correct?
Correct.
Great, thank you. So I think importantly, having received direction to be able to move forward with this document, when I look at, the relationship between the county, Ontario Health East, Ontario Health, the Ministry of Health, and the Minister's Office, we've certainly received considerable interest from the minister herself and the ministry to be able to move this forward. And the request dating back some time was to put an application forward so that the ministry could move on this. Knowing that we have AMO coming up and some key meetings, we felt it very important to get a document in the pipe, so to speak, so that the ministry and minister could be able to follow up on what our intentions were. So when we talk about the new program and what it aims to address, certainly the primary care shortage. You'll often hear from primary care physicians and others that this is not comprehensive, full scope primary care, and at no time have we asserted that it is, but we do recognize that it meets the needs for the most part of many of the 30,000 or 27,000 unattached patients in the county. And in fact, it also meets the need of those who have low clinical acuity, meaning they're not necessarily emergently sick, but that they have a health concern that can adequately be addressed using technology, the availability of primary care physicians through technology, as well as being complemented and supported by community paramedics to extend the role of primary care in the community and in fact into people's homes. When we look at groups that are being served well, certainly vulnerable seniors, those with mental health issues, and also those from a socioeconomic perspective that may be disadvantaged. And the chair spoke to that earlier related to the vaccine campaign. We know that those with low health literacy are less likely to access service if there are barriers to access. We believe very strongly that VTAC has the least amount of barrier associated with accessing primary care and receiving the support from physicians and community paramedics. I think it's also worthy of note that when we look at what the role of primary care and community paramedics is that neither of those are full service health options either. We need to recognize that primary care and community paramedics are often a gateway to other specialties and other services in the community, whether that be related to mental health support, advanced diagnostics, or seeing a specialist such as a cardiologist, or being referred to other specialists for other health concerns. The family health teams across the county have been exceptionally collaborative, both with VTAC, but also in the development of the Ontario health teams. So we think that we're actually a little bit of a vanguard. We're a little bit ahead of what the Ontario health teams are able to achieve, given where the province is at and rolling out the programs. But we also believe that we're also an excellent example of a service and a multidisciplinary approach to healthcare that will support our Ontario health teams here in Renfrew County. When we look at the role of virtual care and technology, certainly our family health team has done an exceptional job of using existing medical record technology and support services within the county. So really what we're saying is that we need to continue to do that and continue those services. So there is also an opportunity, knowing that we have a physician shortage in Renfrew County, to also work with our neighbors, such as those in West Carleton, North Lanark, Ottawa West, and be able to get the support of hospitals such as the Queen's Ward Carleton and others who may have physicians who virtually may be able to support us in Renfrew County, and mutually be able to align services better so that those that are using hospitals and primary care are able to do it in a more expeditious and efficient way. So when we look at the background of VTAC, none of these facts should be foreign to members of committee and council and the city of Pembroke, because when we look at what we've been able to achieve in the past 14, now going on 16 months, we have been able to support over 25,000 virtual family medicine encounters and over 5,000 community paramedic at-home visits. These are incredible numbers when we look at what's also been going on, and that being the 50,000 or so COVID tests. So we're able to address a wide variety of clinical issues, albeit not everything to everyone. If you are an exceptionally complex older adult with multiple comorbidities, multiple disease processes on multiple medications, this may not be the service for you, but at least this can be a portal or an entry service for you so that we can help you to get the level of care that you need from a geriatrician, for example. When we look at the visibility of this program, the committee, council, the warden, and the chair have done an exceptional job of having the national, the CBC radio program, as well as various print media and podcasts, really singing the praises of this innovation. And I think it's in the province's best interest to continue to evolve VTAC, but also to make a sustainability model. We often talk about innovation coming out of desperation. And we know in rural Ontario, we have a big problem, but we also come forward with a solution. And I'm very proud to say that it's not only an idea, but it's actually a proven solution that requires policy support, as the warden said, related to physician funding, but also policy support so that it can continue to evolve to support the role of the OHTs, primary care, hospitals, paramedic services, and really the myriad of things that municipal government support, such as long-term care, public health, community and social services. By any definition, these are all health services that VTAC is able to support. So when we look at the context of the new program, we're very concerned about rurality and ensuring that those in decision-making positions understand the issues with transportation, the geographical challenges, but also looking at how technology can assist us in overcoming some of those very real hurdles for our residents. When we look at the shortage in Renfrew County, we know that physician recruitment has been an ongoing effort, has been a significant effort by both lower tier and upper tier municipalities, hospitals, and everybody who has skin in the game in terms of making sure that we have enough doctors for the people that live in Renfrew County. But we know that we're falling short by about 30% despite all of these incredible efforts. However, VTAC has been able to shore up a significant amount of the challenge associated with that coverage. When we look at a quarter of the population or so not having access to primary care physicians, there is a discrepancy, in documents right across the county of is it 27,000? Is it 30,000? Well, the reality is we have physicians retiring on a regular basis, and that number is continuing to climb because many of the new physicians will not onboard as many patients as those retiring physicians. So in many respects, and the warden I'm sure could speak to it better than anyone, you have to hire multiple physicians to be able to take up the wait list of a single physician that's retiring in the county. So 27,000, 30,000 will soon become numbers of the past, and that will continue to climb despite our best efforts here in Renfrew County. When we look at our population, certainly we have the makeup looking at the age of our population being over 65 compared to the provincial average. So if we're sitting at over 20% and the provincial average is at 16%, we know that with advanced age come advanced complexity and increased health system utilization. The worst time in your life to not have a family doctor is as you grow older and your health systems become more complex. Again, we know that VTAC is not going to be all things to all people, but we do know that it is a significant lifeline to those who do not have a family doctor or are not able to access a family doctor when otherwise their only options would be to call 911 or go to an emergency department. And again, for good reasons, both economic and clinical, people are very well served through virtual options, either as a total solution or as a gateway, because we know that some people have called VTAC and spoken with a physician or a community paramedic, and the advice has been, no, we think you should be going to the hospital. That unto itself is reassuring to people to know what their best option is, given their presentation and their condition, and it gives them control over their health status, but also allows them to make better decisions going forward should they have a recurrence. So when we look at the issues related to primary care, certainly where physicians prefer to live has a significant impact on rural areas. They have spouses, they have families, there are employment issues related to employing the family members of physicians. Looking at cultural diversity in rural areas and what attracts culturally diverse physicians to practice may in fact be access to service or family members. And when we look at the number of people graduating from family practice residency programs, that's becoming a strain on the system as well. So when we look at Health Force Ontario, we haven't had a representative in the area for 18 months, and that person's not been replaced. The role of Health Force Ontario was to recruit and to be able to support physician coverage in our area. So this is continuing to be difficult for us in Renfrew County. And we look at the overall operating model. I think it's important that we understand that we have a relationship to 211, we have a relationship to 911. But when we look at medical reception and what patients' first point of contact is in the system, we, as part of today's report, will be onboarding the role of medical reception so that we have both the patient-facing administrative part of the system, but that we also will we'll be scheduling the physicians, and we'll have the ability to track the status of the patients, the appointments, and continue to evolve the system. As the chair said, this was put together very quickly at the outset of the pandemic, but rest assured there have been multiple meetings every week since the beginning of the pandemic that have evergreened this program, that have made it contemporary and continue to evolve based upon the experience of our patients and the experience of our clinicians within the program. So when we look at how that's evolved, we now have a robust emergency electronic medical record, which the county is administering. And we also have the ability to encourage people to register with Healthcare Connect in hopes that they can get a family physician within the county. So when we look at what this clinical flow would look like, Mr. Chair, we can certainly look at multiple points of entry into the system. But I think it's important to really use this illustration to recognize that it is a complex system. We have specialists, health services, social services, public health, labs, hospital emergency departments. But really our goal, as you can see from the patient and family perspective, is that we have a toll-free number, a medical receptionist, just like they would in a doctor's office, will intake and triage your request. We'll make an appointment for that booking. And our goal has always been same-day service. But we now know that we have more people calling than we have physician availability to be able to service them same day. And that's a significant challenge and something that will drive people to make poorer choices because we can't serve them on the same day. So we'll need to, as we have in this document, make that aware to the minister that not only do we want to do what we've been doing, we need to actually grow this program to stay ahead of the challenges. So we have secure messaging, telephone, video conferencing, and enhanced video available. We also have community paramedics for in-home visits and remote monitoring. So it is truly a patient-centric service that is virtually barrier-free. And from our perspective, something that we need to continue to grow in Renfrew County, and I think celebrate that it is a Renfrew County solution for the people of Renfrew County. And that's why we know those in Ottawa West and other areas are very interested in our success here and are prepared to step up and support us from a staffing perspective and also from a political perspective to show that they believe in what we're doing and in fact want what we're doing in their jurisdictions as well. So we also have innovated a number of ways with pharmacies, for example, but also serving francophones. So we have over the phone language interpretation services available, knowing that we have a significant francophone population. And we're also very culturally sensitive to the needs of our First Nations within the program, and they sit on our advisory committee on a weekly basis for our meetings. So when we look at hours of operation, we look at community paramedics being available throughout the week, and then the family physician and medical reception being available 7 days a week from 8 in the morning until 10 p.m. And we know after 10 o'clock, even when we were providing full 24/7 service with primary care, that those calls become far and few between, 1 or 2 calls in the overnight period. So we have staff medical reception to answer those calls, and then they can redirect them to community paramedics after hours or book the person first thing the next morning for their visits. When we look at the volumes, family physicians conduct about 100 patient appointments every day, about 3,000 a month or 36,000 annually. And when we look at the community paramedics, we tend to maintain about 100 patients on our roster. These volumes would increase once the program scaled up. So we want to decrease our wait times to, on average, about 15 minutes maximum. Looking at patient engagement, we want to ensure that it's a co-design model using a patient advisory council and truly a patient-centric model. And then looking at physician compensation. So I think that this is directly to the warden's comment earlier, and I fully support that we make clear that physicians through our model would be paid through OHIP sessional fees or H codes at the $220 per hour weekends. And what we are saying is that the province need to continue to support these H codes and the policies supported to these H codes on a go-forward basis. So I wholeheartedly agree that this is important, and it's something that I think is fundamental in terms of asking a physician to give up their time to be available for phone calls. And we believe that the H code model or the hourly rate model versus the the piecemeal model of you pay this much, so much for an assessment or a prescription and so on and so on. We believe that the hourly based model is the most incentivized model for physicians and roughly equates to the same cost as the fee for service model, but provides significantly greater reliability for physician billing and for our administration. When we look at sponsoring organizations and partners, Mr. Chair, certainly the Queens Park Carleton has stepped up, as have the Emperor Regional Health, primary care teams across the county, and many of the hospitals have been very supportive of this as well. The reason Queens Park Carleton is important is they have access to a significant group of physicians who can work virtually and support Renfrew County from living in the city for all the reasons that we spoke to previously. But our goal and what we've been able to achieve is, depending on which services are open, you may recall this past year at times you've not had access to your family doctor, or surgeries have been canceled, or access into urgent care has been canceled. So we've been able to tip into different physician groups based upon their availability of providing in-person services. We now have the ability to cast a wider net to be able to attract physicians who have an aptitude towards virtual care and those who appreciate and understand our scheduling model. So you can imagine a physician signing up for a 4-hour shift, for example, and being able to literally work from anywhere. Our goal, though, is that they understand Renfrew County, and ideally they are from Renfrew County and in Renfrew County. But at the same time, we don't want to draw down on the same resources and not make available those people for in-person care, should it be possible, such as your standard family doc. So when we look at the partners, really they come from across the system. But when we look at the groups that we're relying on, we are in close contact with all of the partners in our 2 Ontario health teams in Renfrew County. And that is part of what's garnering the interest of Ottawa West being a part of the Four Rivers OHT, saying, you know what, really, if we adopted this could become one of our first success stories of the OHT by supporting VTAC, because it does align very, very closely with the goals of government. And I don't think that, this isn't about not doing that. This is about acknowledging that in their development, they're saying, hey, all this checks most of the boxes, if not all of the boxes, of what an OHT needs to accomplish. So if we need to do that under the policy umbrella of the OHT, that's fine. But we know that this aligns with the goals of government. And I think that that's key in terms of our articulation of who we are and what we're doing with the province. We're not doing this in isolation. And I think importantly, it aligns not only with the province's goals, but it also aligns very, very closely with what Council has stated, its desire to support the health and well-being of our community through a transaction such as the VTAC. When we look at related plans, certainly engagement opportunities exist. We started off within 2 weeks getting this up and running. Now we have the availability to be able to engage and consult more broadly, and that's one of the tenets of patient-centered care and co-design. So that has been identified within our communication plan. Our risk management plan is always about the availability of health professionals. So something that we need to ensure that the design of the program not only meets our needs as an administrator, but also our clinicians' needs by being able to work from home, providing them the necessary technology, and being able to give them adequate time to do an appropriate assessment and be able to follow up with patients. And then when we look at, primary care and virtual health, there are significant advancements, not only in the technology associated with that, but there are issues of personal health information and privacy, availability of devices such as remote monitoring, and being able to provide training for our health professionals as we go forward. So our quality assurance management and improvement plan certainly look at structures, processes, and outcomes. And it's a key component to the robustness of the VTAC program as we go forward. So we have a plan that does outline that based upon our previous experience, but also our go forward. When we look at the costs associated with these programs, again, I had said previously that there was an error in the numbers. Some of these costs are to be annualized and some of them are prorated on 7 months. So when we look at that on a go forward basis, we just want to make sure that from the province's perspective, they're paying for things that are not double dipping. So such as physician salaries, those that can be billed through OHIP and the H code model that we're proposing are funded that way. And really, this is all the back office to be able to support those functions. With the addition of a medical lead responsible for recruiting and maintaining the team, but also medical reception, language interpretation, community paramedicine, and then one-time costs related to the EMR or electronic medical record, excuse me, the project manager, and the total evaluation. So when we look at our timelines and deliveries, really our goal here is to move this forward very quickly with the province. That policy doesn't happen, doesn't necessarily, but thanks to the warden, the chair, and others, we have the ear of government to be able to move this forward. So certainly our partnerships and MOUs have been achieved based upon our local activities and the transferring of what was previously our family health team to the county's functions. The hiring of staff and medical reception will occur by August 30th. Communications plan and rollout, program launch, and third-party evaluation are key components to this. So when we look at how we're going to evaluate, we're doing this very robustly with the University of Ottawa and the Institute of Clinical Evaluative Studies, which we've partnered with before, as you may recall. And then here we also have a list of performance indicators in terms of how we define success, which really is how you define success. And I believe that we've been able to check those boxes. So, Mr. Chair, maybe I will turn it back to you. I'm sorry I've not been able to see your face while I've been rolling through this, so hopefully your eyes haven't been rolling. And then I've been able to cover this based upon your expectations. So I will stop sharing my screen at this point.
Thank you, Chief Nolan, for a very thorough review of the document. Certainly, committee has had an opportunity to read it, but as the warden has stated, I believe this is an exceptional document. For those of us who have some context, some knowledge, have been following along closely, then this still is an incredible primer. But for those who may be unfamiliar with what has been informative towards VTAC as it exists now and as it needs to exist going forward, I think that this is an exceptional document. So with that, committee, I will open the floor to any questions, comments, and I will begin, of course, with Warden Robinson.
Thank you very much, Chair, and thanks, Chief Nolan, for that presentation. So I just make sure that I'm clear in my head here. So the budget that we're looking at, that basically it's $1 million a year, that is what we, through our MOU with Armpire, will be billing them. Is that, am I correct in that, give or take?
Yeah, that's effectively correct. So remembering that what we're billing is based upon today's model. What I just reviewed for you is what we see as our go forward model. So there may be differences, such as the medical director salary may be greater today than it is in what we're proposing. We're proposing a lesser amount with, really more of a sustainability model versus what Armpire Health may be paying that individual. The community paramedic role as well is, sustainability versus, this crisis management that we're in today.
Okay. So if I just made for supplementary, so I think that I can't see anybody reading this document wouldn't think it's the best investment of $1 million that the Ministry of Health could ever do. And again, yeah, and I'm glad you mentioned about the scheduling of physicians, because right now there is some delay in some of the people being served. And I think that's crucial that we have enough physicians scheduled so that we meet the need, because as you said, the need is increasing, it's not decreasing. And that's part of the whole process. If we're not able to address the needs of people at the time that they require the support, they're all just going to start showing up at the hospitals again, which is what we do not want, or getting sicker and then calling 911. So again, fantastic document. So very proud to be the warden of the County of Renfrew when I see something like that coming forward. So to you and your staff, Chief, exceptional work as always. Thank you.
Thank you.
Thank you, Warden Robinson. Any further question, comment? I'm seeing none. I just, there were a couple of points I wanted to make as Chief Nolan was reviewing this. Certainly, Chief, you recognized that VTAC aligns with provincial policy direction and also county policy direction. There's no question, but it occurred to me also that a true commitment towards patient-centered care. I think that there's no question in my mind that our population, it aligns with our population needs as well. In particular, as we are all very much aware, Renfrew County being the largest geographic county in the entire province, that we are widely dispersed, that is, the population is widely dispersed in Renfrew County, our access to that entry point, which recognizing, of course, as we have constantly reaffirmed, this is not wraparound primary care, though I think that perhaps through the virtual realm, we may be actually able to increase perhaps access to that through virtual as well. But I recognize, and no one would recognize this more than the warden, who is now engaged in her second iteration as a recruiter of doctors to our community, of the enormity of that challenge. While we have made incredible efforts towards recruiting family physicians to our community, here we find ourselves short something between 25 and 30,000 patients without a family doctor. This is not going to be solved quickly. It is an enormous challenge, and this is an outstanding innovation to respond to that need. Whether there was someone at the center, perhaps yourself, perhaps your staff across the senior leadership of the paramedic service, I cannot ascertain in particular, but I know that there are so many elements that have now informed where we have, and I think of the Health Links program, I think of the community paramedics program, I think of the remote monitoring that was stood up initially towards respiratory and diabetic, I believe, certainly COPD. All of these things are threads that have been sewn into the tapestry that is now VTAC, that there is a great deal of background that has led to this position. So if, as the warden has said, this is essentially a rounding error from a provincial or even from a Ministry of Health perspective, and yet it is an incredible value to the residents of our community. So once again, kudos to this initiative. And of course, the warden, myself, and certainly the senior leadership of the County of Renfrew is going to continue to lean way in on ensuring that this does continue, that this need is recognized and this innovative solution is there. Having said all of those things, I'm going to go back to the agenda. And I will read actually the resolution towards moving into the administrative role after the incredible effort that has been stood up by the Arnprior Family Health Team, that this is now being transferred as was discussed in June. So the recommendation is the Health Committee recommend that County Council adopt a bylaw authorizing the warden and clerk to sign the memorandum of understanding between the County of Renfrew Paramedic Service and Arnprior Regional Health, transferring operational responsibility for the Renfrew County Virtual Triage and Assessment Center, RC VTAC, to take effect August 29th, 2021, and to be in effect until March 31st, 2022, unless an extension is mutually agreed upon at the next session. With that, I would like to invite a mover, please. Moved by Councillor Lafreniere, seconded by Councillor Grills. Once more, committee, any further question, comment? I would actually invite, if I might, a recorded vote on this, please.
I will, Chair, thank you. I will just need to pull that up on my screen. I just need to, Chair, if I just take a minute here to adjust my spreadsheet. I don't have one that is specific to Health Committee.
I should have sent you this request earlier, Mr. Morris. I certainly will defer. And I will also wish to remind committee, you may recall, recorded votes at committee level are not weighted. It is simply a vote in favor or opposed.
Thank you. Okay, we will start, sir, if I may.
Absolutely.
Okay, Councillor Bennett, for or against?
For.
Thank you. Councillor Doncaster, for or against?
For.
Thank you. Councillor Grills, for or against?
For.
Thank you. Councillor Love, for or against?
For.
Thank you. Warden Robinson, for or against?
For.
Thank you. Councillor Lafreniere, for or against?
For.
Thank you. Mayor Lemay, for or against?
For.
Thank you, sir. The vote is unanimous, Chair.
Mine will make it unanimous. Mr.
Thank you, Chair. I apologize.
Unequivocally. That would have been a significant oversight since I was seeking a recorded vote on what I believe to be a fairly significant endeavor moving forward. So I will thank you to put that X in that box, please.
Thank you. Now it is unanimous, Chair.
Thank you very much. That does conclude the emergency services report. So I would invite at this point a motion to accept the emergency services report, please. Moved by Councillor Bennett, seconded by Councillor Love. Any further question, comment? All in favor? That is carried. Thank you. And thank you once again, Chief Nolan. With that, I am very pleased to welcome making his inaugural long-term care report to the Health Committee, Mr. Mike Blackmore, please.
Thank you, Chair Donahue, and good morning to members of committee. The long-term care report starts on page 43 of your package. So items number 1 and 2 are the statistics for each of the manor and the lodge for the end of July for admissions. And just to note that, keeping in mind that we're currently, both homes have set aside 2 respite beds and 2 long-term care beds for purposes of isolation. Remembering that we, for a period, we're not taking on admissions. So when we opened the floodgates, as it were, it was our opportunity to ensure that we had sufficient space to allow for isolation. So keeping that in mind, and the fact that this is a year-to-date statistics, we are achieving a 97.5% occupancy target with those rates in mind currently. Item number 3 is the wait list for each of the 9 homes in the county of Renfrew as of June. Item number 4 is an update on the provincial pandemic infection prevention and control measures pertaining to the homes in the province of Ontario. The first being that of restriction easing in step with step 2 that came into effect on July 7th. And the second bullet on page 45 speaks to the stage 3 easing of restrictions that came into effect on July 16th. And of note, significant note with regard to these easing of restrictions, lifting of surveillance testing for all immunized asymptomatic individuals coming into the home. That includes staff, which was quite an undertaking, having to do that for staff on a weekly day, well, several times a week. But with that, again, anyone that's not been immunized obviously still has to undergo the rapid test. We've also allowed residents to resume overnight absences regardless of their immunization status. And again, asymptomatic, fully immunized individuals with no COVID-19 exposure or symptoms no longer require testing, PCR testing. It was that if a person went overnight or on admission, they'd have to have a PCR test, wait for that negative result to come back. And while waiting for that result to come back, they'd be in isolation. So the fully immunized resident no longer has to undergo that. Item number 5 speaks to the Ontario Long-Term Care Staffing Plan. So there's been a pretty significant revision in the plan. The staffing plan is typically something we submit on an annual basis. The province has since revised the plan and changed it to a quarterly report. And some significant new statistics gathered in that report include current vacancies, as well as staff that are currently bridging. Bridging meaning if you had perhaps a PSW that was undergoing training to potentially become an RPN, to capture those stats as well. And this is all tied into the province's announcement to get us up to the 4 hours of resident care per day. Looking at potentially 27,000 frontline nursing personnel. In addition to an increase in 20% of allied health professionals such as physiotherapy, with the end goal being for that to be fully implemented by 2024, 2025. So I'm thinking that this new survey is basically a barometer or a measurement with regard to how far along the province is coming in meeting those goals. And in conjunction with that announcement, the province also asked homes to participate in the survey to look at placement, clinical placement, specifically nursing, just basically looking at what are the barriers for facilities to hold increased capacity for placement, and also asking some questions with regard to what can be done to increase the quality of clinical placement. So both Phil Lodge and the Manor have participated in that survey. Item number 6 is our recruitment video. I'd ask to watch at your leisure. It's not the third of our PSW recruitment videos done in conjunction with Canada Career Academy and Employment Ontario. And a special thank you to Donna Kalo, PSW from Bonnechere Manor, and Robert Lamoth, PSW from Renfrew Lodge, for their role as ambassadors for the homes in the video. Number 7 is an update on the butterfly approach. So costing for a Class D estimate was achieved through Hoban Architects, Wendy Brawley, at a cost of $13,693 for Bonnechere Manor and $15,318 for the lodge. And we're expecting that Class D estimate anytime now. Item number 8 confirms the Accreditation Canada recognizing both Miramichi Lodge and Bonnechere Manor as a single entity for a joint accreditation to take place in 2023. And this it ties into furthers the goals of both homes achieving a standardized programs amongst both homes. Number 9 concerns the Bonnechere Manor roofing replacement, further to strategic goal number 2. And committee will recall that originally Bonnechere Manor was slated for a partial roof replacement at a cost of $220,000. Recently, we received some additional funding through the COVID resilience infrastructure stream for HVAC purposes of $990,000. Knowing this, we had reallocated $250,000 back so that we could complete the entire roof project at a cost of $472,000. And given that this is time sensitive in terms of roofing and weather conditions, we thought it important to get this on the books or get it started as soon as we could. And with that, the Chief Administrative Officer, Clerk and Warden passed bylaw number 8921. In keeping with our policy GAO1 procurement, given that this was a project over $50,000, tenders were requested, for which we received 6, and the winning submitter was Perth Roofing at the lowest bid and having met all the conditions at $398,000. Next item is a resolution. And Chair Donahue, I don't know if you want me to stop there or.
Thank you, Mr. Blackmore, actually, that is a very appropriate place to stop before we get into the resolutions. So with that, committee, we are going to go back to item number 1. Furiously scrolling. It is found on page 43, the Bonnechere Manor resident statistics. Any question or comment? Item 2, the same statistics for Miramichi Lodge. Item 3, the waitlist information. Item 4, very pleased that it is becoming a shorter report on the COVID-19 pandemic update from long-term care. It was, of course, recognized as the singular largest urgency as the vaccines are being rolled out. Very pleased to have this size of report on a going forward basis, hopefully. Item 5, Ontario's long-term care staffing plan. I just had one question, Mr. Blackmore, and this is to provide some context. You and I have had some discourse on this. The staffing plan does need to, each home will have particular exigencies. Is there a concern that this could potentially be a too rigid a plan that needs to have built-in flexibility so as to not unduly constrain our needs, not just in the long-term care homes for the County of Renfrew, but perhaps even between the lodge and the manor, and certainly writ large right across the province. Each home has its own unique pressures and requirements. Is that something that whether we or perhaps Advantage might be staying on top of?
Thank you, Mr. Chair. 2 days ago, I would have said yes, but I just had recently come across communication from Advantage to the minister, specific to the commission's identifying a specific percentage of RN, specific percentage of RPN, specific percentage of PSW in the makeup. And Advantage had also raised their concern with regard to, taking away the home's ability to staff in accordance to what's available to them or what works for that home, and received assurances from the minister that the province has no intention of going ahead with that at this time.
Okay, pleased to hear, because there are on occasion, perhaps on numerous occasions, the law of unintended consequences as a nasty habit of intervening here. So it is something certainly to keep close watch on the potential for a micromanaging perspective. Thank you for that response. Item 6, the recruitment of personal support workers. I have reviewed the video. I think it's outstanding. There's a very local flavor here in Eastern Ontario. Very pleased to see that, and it does give in a very condensed, abridged format much information to those who may be considering this career. Item 7, the Butterfly Project update. Item 8, the Joint Accreditation Canada update, wherein both of the homes will be on the same schedule and will be accredited as County of Renfrew long-term care homes rather than on an individual basis. Very pleased at this. And finally, item 9, the roofing replacement. Just on this item, and I know that it certainly is inferred in the report, but just to be clear, this was a budgeted item, being a budgeted item in the delegated authority that Council granted to the CAO at our June meeting, due to the fact that we did not sit through July. It was that authority exercised by the CAO that has approved this. We are, of course, back into our meeting schedule, so that delegated authority has now terminated. Any further questions, comments on the roofing replacements? With that, then, Mr. Blackmore, back to you for resolutions, please.
Yeah, number 10 is a resolution with regard to signing authority for Bonnechere Manor. A recommendation that the signing authority for Bonnechere Manor Trust's Administrator Bonnechere Manor I'll start over. That the signing authority for Bonnechere Manor Trust accounts be updated to remove Shelley Sheedy and add Kimberly Saunders, Administrator of Bonnechere Manor, effective immediately. Further, that 2 of the following 4 names have signing authority: Jeffrey Foss, Kimberly Saunders, Sandra Block, and Kim Prentice. And this is further to Shelley Sheedy, Director of Long-Term Care, retiring as of June 30th, and Kim Saunders being the successful applicant as the Administrator of Bonnechere Manor.
Thank you very much, Mr. Blackmore. Of course, this is typical housekeeping, administrative, and important nonetheless. Can I have a mover, please? Councillor Doncaster, seconded by Councillor Grills. Any discussion? All in favor? That is carried. Thank you. That does conclude the long-term care report. So I would seek a motion to accept the long-term care report, please. Councillor Bennett, seconded by Councillor Love. Any further and final opportunity for question? All in favor? That is carried. Thank you very much, Mr. Blackmore. Got the first one under your belt.
Thank you.
With that, then, Mr. Morrow, I will yield the floor to you for the administration report, please.
Happens once every meeting. I forget that mute button. Thank you, Chair. The administration report, Chair, is contained on page 48 of the document. It essentially consists of 3 items. The first item in the first 2 items in the report, Chair, are there just given the timing of where we are with AMO, and they are contained in all of the committee reports that went out. And the purpose in doing that was to make sure that all members of County Council were aware of the 2 sets of AMO documents in advance of the AMO meetings. So hence being provided in the document. So item 1, Chair, are the AMO papers that were produced by the County of Renfrew in preparation for our delegation requests. We made 5 delegation requests and were successful in receiving 3. We received a delegation to Minister Elliott specific to VTAC, and received a second delegation to Minister Rod Phillips. So that has been approved, and that will speak to the Commission's report on long-term care. And finally, we were unsuccessful with a delegation request to Steve Clark. However, we were provided a delegation to PA MPP McDonnell, and that is specific to the seniors housing strategy. So all those documents are attached, and all those position papers are attached for committees awareness. Also attached are the same EOWC briefing notes in preparation for the Eastern Ontario Wardens Caucus. I thought there was some value in attaching those documents as well, just knowing the overlap in topics between the organizations, the County of Renfrew and the EOWC. You know, the comments I made yesterday, again, I'll make them again today. This demonstrates the value in having our warden as the chair of the EOWC. Most certainly, Chair Robinson has been able to bring issues that we feel strongly about here at the County of Renfrew to the EOWC, and I think that is reflected in those EOWC briefing notes that are attached to the document. So again, an important relationship we have with our warden being at that chair. So serving as the chair. Finally, Chair, is the attached appendix is the letter dated to Chair Robinson from the chair of Renfrew County District Public Health relating to the opioid crisis, and requesting a conversation with the warden on that very topic, and a topic of communication between our 2 organizations. I'm confident the warden will have maybe something to add on that one as well. So, Chair, I will leave it at that. Thank you.
Thank you very much, Mr. Morrow. Very concise report, very much appreciated. Committee, we will go back to information item number 1, the AMO delegation position papers. Any questions, comments? I just have one comment. I certainly want to, I think that throughout there is a theme, and I think that this will carry forward into information item number 2 as well, that it is the seeds that have been planted a few years back with respect to the position that municipalities have within the health sector, certainly funded not by property tax dollars, but largely funded by provincial dollars, and going forward even more so as we move in. But I think that it is certainly recognizing the challenges, particularly in rural Ontario, but enormously pleased at the level of consultation that we have been provided at AMO this year. And I certainly also must make note that there has been a very good relationship established between the County of Renfrew and Mr. Jim McDonnell, certainly through the official plan process. I know that Mr. McDonnell had been very engaged with the County of Renfrew in that process. So I'm very pleased actually that Mr. McDonnell continues in that role, given that relationship has been long established now. And I think that through various threads, we can continue to advance the needs of the residents of Renfrew, of the County of Renfrew. And of course, when I say that in this group, it is the geographical County of Renfrew, recognizing, of course, the residents of the City of Pembroke. Item number 2, the EOWC briefing notes. Once again, as in number 1, and perhaps picking up, Mr. Moore, on your comments, and as I had indicated, even with respect to the presentation on VTAC, I think that certainly the persuasive skills of Warden Robinson and also yours at a staff level have advanced absolutely some of the priorities for the County of Renfrew. But I dare say that they have probably received traction at the Eastern Ontario Wardens Caucus because the County of Renfrew has simply been ahead of the curve. And there is a recognition of the innovative initiatives that we are doing here in Renfrew County and how these can be expanded and extended to larger parts of the province of Ontario. So I'm fairly confident that the traction that we are getting on these is because of the incredible efforts and work that has been done on numerous files that are clear in the briefing notes. With that, item number 3, the opioid crisis. Warden Robinson.
Thank you very much, Chair. So this is the second letter that I've received from Chair Aikens asking to have a conversation regarding communication between the health unit and the County of Renfrew. So I do plan to respond in writing to her and invite her to meet with myself and Mr. Morrow to discuss whatever the communication issues are that she sees, as well as certainly, going forward, her ideas about mental health and the opioid crisis, because obviously our community paramedic service is facing that on a daily basis, trying to assist folks. It's very important and certainly an issue when we talk about the Eastern Ontario Wardens Caucus that is shared with an issue that every member of the caucus is facing as well. Significant jump in the level of the number of opioid uses and the overdoses that are happening within Eastern Ontario. We're no different than anywhere else in Ontario, but what we do here is when we recognize an issue, we deal with it. We're not going to stick our heads in the sand. We're going to try to help and try to figure out a way to help our residents. So that will be certainly the first step of many, I suspect, going forward to work in collaboration with the public health unit. Thank you, Chair.
Thank you, Warden Robinson. Councillor Renfrew.
Yes, so there are some residual complications when it comes to the opiate crisis. Earlier in Michael Nolan's presentation, he talked about the doctors that have recently retired. a family doctor recently in Pembroke retired, and it stated in Mr. Nolan's report that a great number of his patients were opiate dependent, which is obviously causing an issue for a lot of those people that maybe are dependent. But the innocent victims in all of this are the people that are legitimately in need of chronic pain management through opiate. They can unfortunately not be helped through VTAC. These are people maybe that are chronically in pain due to past surgeries, injuries, and they right now have to go to the emergency because they cannot get a prescription for longer than a week or two. So they are also victims of this opiate crisis because of the limits they're being put on and restrictions in renewing their prescriptions. So I don't know how that can be managed, but I know that there is a large part of our population that are not addicts per se, but really need that form of pain management. So this is also unfortunate, and I don't know if there's any way that the warden could help with that. I doubt it. It's just a matter of assessing these patients now that are orphaned and saying, is this an addiction issue or is this a real need? That's all.
Thank you, Councillor Frenia. I will certainly invite any comment, perhaps that the chief may have on this. I do want to be very careful. I certainly understand the demographic that Councillor Frenia is referring to. This is a hydra. The opioid crisis is a multi-headed beast. And is going to require a multi-sectoral response. And I would probably not use the term, or I would shy away from the term of legitimate. I think that there's a mental health component to this. I think from a harm reduction that this is going to engage all hands. All hands are going to be required to be on deck. I think that this needs to be viewed, and we need to be careful not to in any way limit the discussion. I think it needs to be a very broad discussion because I think that the drivers of the opioid crisis, as I said, it is a hydra. I wonder, Chief Nolan, if you want to, if there anything that you wish to add.
Yeah, thank you, Mr. Chair. I'm not sure which head to be looking at on this issue because it is incredibly complex. I will say that certainly VTAC has a role in terms of understanding individuals' situations and trying to assist them in getting the most appropriate support. So there may well be a role as it pertains to the use of opioids for pain management in the community. There's another group that are significant opioid users therapeutically, and that is the palliative care community. And we work very closely with that community and community paramedicine and the frontline 911 paramedics have all received training in how we can best support that population, which is an opiate user community. There is discussion amongst the OHTs and some of our hospitals as to how they can better provide pain management support. And opiates are but one of the available modalities, if you will, in terms of managing pain. Some physicians may go to opioids relatively quickly in terms of the best option for pain management. Certainly those people who have used opiates in the past for pain management, that may well be the best choice, or there may be alternatives that VTAC or other physicians could assist patients in exploring, depending on how long you've been on opiates and a number of complicating factors. But without a doubt, the availability of prescription-based opioids in the community, especially amongst the frail elderly population, does have a relationship to those drugs being circulated on the street inappropriately. We did see a number of fentanyl thefts, for example, and then they take a patch, cut it up, and we get a run of that for days or weeks within the county. So really the best course overall is trying to reduce the amount of available opioid in the community. VTAC will not be, at its current state, will not be renewing opioid prescriptions over the phone, I think for obvious reasons. And even in fact, the emergency departments are very hesitant to do that. So it leaves this population really in a lurch because they don't have the reliability in the ongoing relationship with their primary care physician, should they be lucky enough to have one. And we also know that there's a relationship between opioid use and socioeconomic status and a number of other issues that can lead people towards abuse of these substances, or use of these substances, I think is the better, more contemporary terms. So VTAC has a role, but it's not to be renewing prescriptions. The hospitals certainly have a role in the emergency departments, but even at that, hospitals are hesitant to prescribe out of the emergency department, but may provide other alternatives, such as, for musculoskeletal fractures, the use of Advil and Tylenol together, for example, in some studies suggests that it's as effective as opioids for pain management in the short-term use. So a lot of people don't know that. So these are some of the examples where we need to, I think, take a system as a whole approach, but acknowledge that, there is an illegal drug trade of opiates that and other substances that may have opiates in them that are leading a lot of people down a very dangerous path in Renfrew County. And we need to be very empathetic towards that use, because it can be tied to mental health issues, but it can also be tied to recreational use with unintended consequences, such as speedballs, where they're mixing in opioids with cocaine, for example.
Thank you, Chief Mullen. Councillor Doncaster.
Thank you, Mr. Chair. I think I've mentioned in the past in one form or another, as when I attend FCM committee meetings, the opioid crisis comes up in one form or another. I don't have significantly new data, but annually I know there's around or over 4,000 Canadians who die from opioid overdoses, and over 90% of those deaths are ruled as accidental. So the issues that come along with that. The other one, I just wanted to point out that in the federal government's budget of 2018, there was $231 million allocated to help tackle the crisis. What those programs are and that I don't have all the details, but this is, and certainly acknowledge this is not a local issue. This is a Canadian issue for sure. And as in similar to music, everything seems to start on the West Coast and travels east. So we seem to be experiencing this significant issue a couple years after it started in the western part of this country. That's all I have to comment on. Thank you.
Thank you. Seeing nothing further, can I have a motion, please, to accept the administration report? Councillor Love, seconded by Councillor Lafreniere. All in favor? That is carried. Thank you. Item 9 is the Board of Health minutes from May 25th, 2021. I cannot recall, Mr. Morrow, do we accept those by resolution? All right.
Motion to receive, Chair.
Motion to receive. Okay. Can I have someone to move a motion to receive? Councillor Doncaster, seconded by Warden Robinson. Any question, comments? Warden Robinson.
Thank you, Chair. Just when I was going through the reports, which I really do appreciate reading, there's a question about provincial appointments. So I'm just wondering, is there a vacancy right now on the Board of Health for a provincial appointment?
There is, that's correct. It has been vacant, I think, since, if memory serves, 2019, actually. And it is not, public health is not unique in this. Probably most folks on this meeting this morning would be aware of vacancies that exist in police services boards. If you just visit the Public Appointments Secretariat webpage from the province, it is a significant challenge in moving forward. So yeah, it has been vacant for some time, and I will also acknowledge that I think this perhaps was being driven more so from the perspective of the transformation that was articulated in public health by the province pre-COVID. Because even in the public appointments that still are sitting on the board, they had for a number of years had been 3-year appointments, but they have consistently now been year-over-year appointments. So I think that's probably being driven more from a policy perspective, but the vacancies are certainly of concern.
Well, that's why, if I may, that's why I was wondering about this, because I knew that the appointments were suddenly, 1-year terms. So I'm trying to figure out the reason why they wouldn't, at least if they're not going to get rid of this position, then why they wouldn't at least do it on a year-to-year basis.
Well, and one of the things that of course is the certainly any of the boards that have public appointments can be involved in the process of making recommendations to the Public Appointments Secretariat, but the appointments are based on an application format. So at this point, I do not know if there has actually been applications for that vacancy on the Renfrew County District Public Health Board, but it is disconcerting, disquieting, I suppose, both here and again with respect to police services boards at the lengthy gap from vacancies to fill. Anything further on the Board of Health minutes? Seeing none, all in favor? That is carried. Thank you. Is there any new business? We do have a requirement for a closed meeting this morning for labor relations or employee negotiations. That'll be section 239 something. So with that, just prior to, I think in closed, we have adopted a procedure wherein I would seek a motion to move into closed and to approve that, at which point then Mr. Benke would vacate while we're in closed, but then when we return to open, Mr. Benke will once more return, that we will close meeting. Is that accurate, Mr. Morrow?
That would be correct, Chair.
All right, thank you. Can I have a motion to move into a closed session then, please? Councillor Bennett, seconded by Councillor Love. All in favor? That motion passes. The Health Committee has returned to open session. We will return to our agenda at item number 12, which is the date of the next meeting. It is Wednesday, September 15th, 2021, same channel. Well, perhaps that's not accurate. We may actually be in person. That is to be determined. With that, then, I would invite a motion to adjourn, please. Moved by Councillor Bennett, seconded by Councillor Lafreniere. All in favor? Thank you, Health Committee. I think that has been the shortest recorded version of the Health Committee.